I'm a medical officer at Nyeri County Referral Hospital, and I have a story. I started working in casualty, I think 3 months prior to the strike, and I see almost 200 to 250 patients in a day. I can assure you by the time I'm leaving the hospital, I don't even know my name. I'm totally fatigued. And while you see lots and lots of patients in casualty, I realized one thing. All these patients come with a peculiar smell. And as you examine each and every patient, you realize that these patients are clean. Because when patients come to doctors, it's like they're going to church. They dress up, they wash up, and they are ready for doctor, And as you examine these patients, you realize that they are clean. They are very clean people. They have dressed to the best of their abilities, but they still have this peculiar smell that I ignored for a few days. But then it made me question, what is this smell? The smell of misery, the smell of hopelessness, and the smell of poverty. I realized poverty has a smell. These people sell their lands and cows to come and see us so that we can help them cheat death just once. And we're not able to do that. When that patient comes to you and he tells you or she tells you her problems and you want to prescribe medication, you have to start bargaining with the patient what medication to give them, because the pharmacies don't stock medications anymore. Labs don't do investigations. The X-ray machine is broken. The CT scan is broken. And it makes me wonder, how am I living up to my oath? How am I doing justice to my patients? And for how long can I keep quiet? That smell has never gone out of my memory. These people who can sometimes afford NHIF that is useless because they cannot afford any services in the hospital. How am I helping my patient? What can I do to change this? Healthcare has faced historical injustice right from colonization. And we've gotten to a point where our tanks are empty and we need refueling. As a doctor, I can assure you that we all want to go back to work. We love our jobs more than anything. We're in school for 7 years and even more so that we can do what we do best. But we cannot continue working with no infrastructure. We cannot continue working as mercenaries. We are no longer doctors. We just supervise immediate deaths and take away hope after giving hope. We feel like it's very cruel to make a doctor take an oath to save lives and then put them in the forefront to watch patients die. It's the reason why we cannot go back to work. You cannot ask us to go back to work on humanitarian grounds in inhumane conditions. Give us basic drugs, give us investigative equipments, give us our lab reagents. Take us back to work in the right conditions where we can actually save lives. I don't want to smell that misery, poverty, and helplessness and not do anything about it. I'm a doctor. Let me be a doctor. Give us equal pay for equal work. Give us infrastructure.
Hello, my name is Dr. Mohammed. I work in the coastal region in a public hospital. A few years ago, while I was studying fresh in internship, I got an injury, a needle stick injury that was contaminated with HIV, 2 of them in the space of a month. I underwent treatment and I was okay. A few months later, I had a child who was in bad condition, who was also HIV positive and who needed blood very urgently. There was no blood in the entire coastal region, and so the only way to save this child was to donate my own blood. A sample of my blood was taken to Nairobi Blood Bank. Here it was tested, and a few months later I was given the results that I was HIV positive. When the results came back, I was very, very distraught. I didn't know where to go, who to tell. I was worried that I could not continue my life the way I had planned it. I didn't know whether I could ever get married. It was a very difficult time. I spent the next few months in and out of counseling and in and out of private labs so that I could confirm my results, only to find out that the results were negative. I'm telling you my story today because I want you to know the problems that doctors go through in terms of payment for their own services that they give, and the fact that we did not have blood in our entire referral hospital.
I am Dr. Gendo. I work at a county referral hospital in Eastern Region. Medicine, for me, for anyone who's really practiced, is not just treating the body, it's treating a person as a whole. And if you're treating a child, then you find yourself treating 3 people at once. And I remember once we had this boy come in. He was referred from a smaller hospital following circumcision where the instrument that was used was incorrect and he'd got tetanus. And as a result, he was convulsing. Everything was shaking, everything was moving. It was very dramatic. And I remember thinking, I know what this is. This is tetanus. I know how to treat tetanus, and it's just one drug. But the drug was unavailable, and this boy was moving. You couldn't touch him, you could not turn on the lights, you could not speak in his room without him convulsing. And I remember the parents looking at me and just begging me to save this boy. And I knew what to do, but I couldn't do it, and I felt like I was failing them. But in truth, the system had failed us. And while it may not seem like it, this strike is also yours. Because like this parents looking at me, wondering why I'm not helping them. This is a fight, and it's this fight that this strike gives voice to. So it is also your strike. It is not just the doctor's strike. It is those parents' strikes, that child's strike, and your strike as well.
My name is Dr. David, and I currently work on the western side of Kenya. Prior to this, I was working as a medical officer intern in Isiolo District Hospital. And I recall a particular incident where I was called to attend to a mother in the night. It was about 2:30 a.m. And the mother had been a referral from a distant place by the name Merti, which was 4 hours away from Isiolo. She had been in labor for 2 days, and upon arrival, the nurses called me and told me that the baby was stressed and she had prolonged labor. At which point I requested for the ambulance to come and take me to the hospital, and the ambulance took 2 hours to get to my place to pick me, and later on the ambulance broke down on our way to the hospital. That ended up having me to leave, to come out of the ambulance and push it. This was at 3:30, around 4 a.m. And by the time I got to the hospital, the baby had been delivered, but the baby was dead and the mother was just psychologically distraught. It was a very difficult moment to try and counsel the mother. And basically this story highlights the deficits in the system with regards to access to emergency care, whereby a mother could take over 48 hours just to receive an emergency procedure as a C-section.
Hello guys, my name is Dr. Odira Edwin. I'd like to share a story from 2010, back in the day when I was a medical officer in Kisumu. Right now I'm a general surgeon. So we were doing a clinic for surgical patients one fine morning when an elderly lady walked into my room, and from her appearance I could tell that she came from humble backgrounds. I welcomed her to my office. We got over the niceties and went straight to the reason for her visit. So she told me that she had a swelling on the top of her head, which she had had for about 2 years. I examined her and actually found that the swelling was coming from another swelling in her thyroid gland, that is the gland around the neck. So once I had seen that there were already two swellings, I knew that most likely it was a cancerous growth. So I needed to investigate her and make a management plan for her. That's when now the problem started, because this lady had actually walked to the hospital about 12 kilometers from her village. So she could not afford to have any of our investigations paid for. And she had actually walked alone. This lady was about 72 years. There was no one to bring her to the hospital because most of the people around her had actually passed on. So it was a sad case for me. I decided to involve the hospital, and we were able to do the investigations we could afford, but there were some which we're not able to do because of the level of our hospital. Eventually, through cooperation of the hospital administration, we were able to actually establish a diagnosis for her, and she needed to have radiotherapy done. That is, she actually needed to come to Kenyatta from Kisumu so that she can have this treatment done. And right now, I've been to Kenyatta. I know how long it takes when a patient just walks into a radiotherapy center. You come in today, you have at least 6 months before you can actually get to receive your treatment. So the challenges in that she couldn't afford 50 bob fare to our hospital. Now we were asking her to travel to Nairobi. There was no one to take care of her, and we knew that she was going to get 6 months waiting period. We explained the need to her to travel to Nairobi, and she told us that she was going to think about it. We obviously knew what that meant, because from her body language, it was as if we didn't really want to help her. So unfortunately, once she left the hospital, she was lost to follow-up, and later on we learned that she had succumbed to her illness. So as you can see, there's a challenge in cancer treatment in this country. If a place like Kisumu doesn't have a radiotherapy machine, they have to come to Kenyatta. You can see the kind of strain that we're putting into the facility at Kenyatta National Hospital. I'd really like to beseech the government to improve these services so that patients like our lady who passed on at least have a chance at treatment.
My name is Dr. Kibera. I'm a dentist by profession, and I studied here in Nairobi, did my internship at Kenyatta, then I got posted to Samburu County. The actual town is called Maralal. It's about 400 kilometers from Nairobi. It's an interesting place to go to if you're a tourist, but if you're a doctor, more so a dentist, it makes your life a bit interesting. My line of work needs very high quality equipment, which is what I actually used to train with. But when I went there, it wasn't what I actually found. In fact, I found none of it at the government place. So to compromise, I had to go to a mission place. I was being paid by the government, but I can't work at the government place. I have to work at the missionary place. So I could do most of the work which I can do over here, but it came with its own challenges. And I would like to number a few. Let's start with the distance between there and here. It's a day's journey. So I have to wake up at 5 in Nairobi. So I have to be there at 5 p.m. in the evening. One day, remember when we were going, we had a flat tire at night. We couldn't change the tires. So we had to spend half the night there till 12. So I had to hop on a truck, a kettle truck to be specific. I had to hang on it till around 4 a.m. Then I slept on the road till 7. At that point I wanted to quit, but I was the only dentist in the whole place for 1 year and a half. So I saw it unto myself that I owed the population their quality treatment, so I stayed on. But the challenges which I got with the place were so many. At some point I couldn't go ahead. I used to do procedures which are done by dentists in Nairobi, but I used to give the same service to guys in Samburu. What I found particularly hard was blackouts. I could do a procedure and the lights are gone. So my patient is there, they're numb, they're bleeding, but there are no lights. So I have to keep them in that numb state till the lights come back, which is not what I signed up for. It was very difficult to do. And among that, you would find that since I was the only dentist in the whole county, I used to see people from everywhere, from Baragoi, from Arala itself, even from Nyahururu, some occasionally from Nakuru. So I could get there. In the morning, there used to be a long line, more like what you'd get in a polling booth. About 40, 50 people in the morning. So I'd see them from 8 a.m. up until, some days I could stretch it to 9 and I haven't eaten at lunchtime. So I'd see all of them. By the time I'm done, my back is aching. I'm young, but I have back problems. But I'd see them nonetheless, and I'd make sure the work I do is fine, so that none of them could have complaints. And they were happy. I used to get happy when I see them happy, when I see their pain gone, when I see them getting the treatment they deserve. That I could do, but there's only much you can take, especially if you're alone. And the guys at the county government really didn't care much about whether you had the equipment you needed, the equipment you wanted. I used to solicit them to get assistance by way of hands. They'd make promises, but they never did actually came close to actuate any of them. And at that point, I worked and I got to a point where I simply couldn't do it anymore. I just told them I can't, and I quit. Now, if the guys at the county had made health their priority, if the government guys had actually chose to prioritize the people and not themselves, most likely I would have been there working now, seeing to it that I'd be rendering my services to the guys at Samburu. They're really nice people, nice culture. We get tourists because of them. And I was happy knowing that I'm the dentist who caters to their teeth. But if I have to do that, I have to do that under conditions which are humane for me, for them too, and not what I was exposed to for that duration which I was there.
My name is Daniel Ojuka. I am a consultant surgeon. I teach at the University of Nairobi and work at the Kenyatta National Hospital. I worked in Kapenguria initially for the first 5 years as a consultant surgeon, and I was then the med sup as well. As a med sup, administratively, when I went there, the government was giving 1.5 million quarterly in order to buy drugs for patients, in order to buy food, to buy fuel, to buy basically everything that is operational. That reduced over the 5 years that I was there to the point where when I was leaving it was 400,000 per quarter. Of course, it meant that you had to charge patients more in order to keep the services at the level they should be. The government was supposed to be giving drugs every quarter again, but there are many quarters that the government didn't bring the supplies of drugs. And so you have to use resources from the patients to buy drugs. And of course that means the hospital is always in some form of debt. So there are a lot of things you know this, if I got this equipment I would do, but you didn't do it because basically it's not there. So the doctor that practices in the periphery really suffers. Kenyatta was built some time ago with 12 theatre and you expect the many surgeons that are in Kenyatta to use 12 theatre. So that means essentially that Kenyatta is designed in such a way that it is inefficient. You put 4 patients in a theatre list and you're only able to do at most 3 or 2. So if you look at public sector that I have worked in, you really require some heart And I think for me, what the CBA entails is what is required to reform the sector, that is public sector, so that it is efficient and people get the quality of care that they pay taxes for. I think the CBA contains issues that would help us move the health sector to the next level.